Yes, thank you, Dr. Hind. I guess we're preventing you from dinner. We're behind time, and I'll try to. Dr. Ghazi said instead of 15 minutes, you have 2 minutes. So I'll try to do 5 minutes as much as possible. So, as Dr. Hind mentioned, this symposium is sponsored by Janssen. So I'll be talking about bispecific molecules in multiple myeloma. In multiple myeloma, it's a chronic disease that keeps on relapsing, and initially patients get treated based on whether they are transplant eligible or not, with an induction regimen where they achieve some form of remission that is the lowest, the deepest remission you can see. I don't know how to do this, but maybe I can point here. I cannot. Anyhow, and patients keep on relapsing and subsequently need some form of therapy that is mostly different than the previous therapy that was used previously. If you look up here, the myeloma cell has many different targets which could be used for monoclonal antibodies to target these targets. So bispecific molecules, as you know, are having, if you can see that myeloma cell, these bispecific molecules have a target on the myeloma cell, and the most common target currently is BCMA, and there are many other targets, and we'll see in subsequent slides the different targets that where bispecific molecules have been developed for. This bar graph shows you the overall response rates of all drugs that we know that are used in multiple myeloma compared to the new drugs. You can see here bortezomib. I remember the first study, which was the APEX trial, showing an overall response rate of less than 30% in these patients. And you can see here lenalidomide, carfilzomib, pomalidomide, ixazomib, daratumumab. They're all almost below 30% as an overall response rate as a single agent. But you can see here T-cell redirected therapy, including CAR T-cell and bispecific molecules. They are way better than what we used to and we're still using for these patients. You can see cell-to-cell reaches almost 100% here, and for the bispecific molecules, including teclistamab, talquetamab, and elranatamab, around 60 to 70% of overall response rates as single agents. So BCMA is the first antigen that is targeted by bispecific molecules in these in myeloma cells, and this table summarizes the bispecific molecules that have been used so far targeting BCMA. We have alnoctamab, teclistamab, and another molecule, linvoseltamab, and elranatamab. You can see here that the overall response rates ranges between 60 and 70% in these patients, and median PFS is around 1 year, more or less, or to a year and a half in these patients. Non-BCMA, other targets on myeloma cells, the most common one or the most widely used after BCMA is the GPRC5D, which is a G protein receptor C5D. Other targets include the FC receptor H5 by cevostamab, and talquetamab for the GPRC5D. The FDA approved bispecific molecules so far are 3. Teclistamab is the first bispecific molecule that has been FDA approved back in October 2022. Talquetamab in August 9, and which is a GPC5RD bispecific molecule. Elranatamab, which is another BCMA bispecific molecule that was approved back in August 14, 2023. So if we go over the efficacy data, Dr. Ghazi will talk about the toxicity data of these bispecific molecules. So teclistamab has shown an overall response rate of 63% in patients who are heavily pretreated as a single agent bispecific molecule. And efficacy was seen in most subgroups, including higher risk patients. This is the duration of response in teclistamab from MajesTEC-1 study with a PFS of 11.3 months and a duration of response you can see here in this curve. I mean, the green one is patients who have achieved CR, and the blue is overall patients, which is 18.4 months. Elranatamab, another bispecific molecule targeting BCMA, has been looked at in two cohorts, cohort A and cohort B. Cohort B is patients who had prior BCMA redirected therapy, and cohort A in non-prior BCMA redirected therapy, step-up dosing, and every week for the first 6 cycles. So again, overall response rate of 61%. And most of these, what is noticeable in these bispecific molecules, most of the responses are actually deep responses. So 61 overall response rate, but almost 90% of that response is VGPR or more. This is again elranatamab, duration of response, progression-free survival at 15 months, almost 14.9 months, was more than 50% still. This is cohort A of the study, where patients have already been given a BCMA-directed therapy. Again, an overall response rate showing more or less similar to the general group. BCMA redirected therapy before or after. This is the teclistamab that was done in group C, where patients have used a BCMA targeted therapy. An overall response rate a little bit lower than the other group, which is about 55.2%. Talquetamab, a GBC5RD targeting bispecific molecule in Monumental 1. There are 3 arms, 2 different dosage forms, 0.4 weekly or 0.8 every 2 weeks. And these are the groups. Again, overall response rate in these 2 dosage forms, around 74% in all patients. And on the right-hand side, you see patients that have had already a T-cell redirected therapy with an overall response rate of 62.7%. You can see here the median duration of response in the 2 dosage forms in patients who have achieved CR or patients who did not. So again, efficacy data about Monumental 1, talquetamab. This is, the median follow-up was 27 months, 27.6 months in the Q weekly, and the Q2 weekly 20.8 months. And with those with prior T-cell, 21.3 months. Median PFS was about 13.2 months. So overall, very effective modality of treatment on bispecific molecules in multiple myeloma. The beauty, it's off the shelf. Of course, CAR T cells, especially cell-to-cell, has shown probably the longest PFS ever seen in multiple myeloma, but it's yet not widely available, and there are production problems from Janssen itself. I'll present a case. We have had, fortunately, access to teclistamab through a compassionate use program, and many of the patients have been treated in that program. This is one of the cases that I have treated recently with teclistamab, a 64-year-old patient that has been referred to me from the Eastern Province. Not sure if Omar is here. Initially, he was treated with 4 cycles of VRD, achieved PR, given 2 more cycles, achieved CR, and then auto transplant was done back in July 2021, followed by lenalidomide maintenance. In March 22, showed increasing M-band and progression of his disease, around 20 to 25% plasma cells. And cytogenetics showed 1Q gain. So in June, he was started on DARA PD instead of DARA KD. Mostly this was elected because the patient was not, happy to come twice weekly. This was shortly switched to DARA VD because of cytopenias. While on treatment, he again progressed, and he became transfusion dependent and almost wheelchair bound. At that point, he was referred to me. I've seen him back in March 2023 with disease progression. He was almost wheelchair bound, and he was fatigued, and he was getting transfusion almost every week. His hemoglobin went down to 6. So I tried to start him, to bridge him until we get the teclistamab with DARA KD, but his response was not, it was just 1 cycle. Then he was started on teclistamab back in May 2023. So far he received 8 cycles. He did remarkably well. Regarding his myeloma, he achieved stringent CR. His hemoglobin now is 13.5 grams per deciliter, and he is walking. So very good response to teclistamab. So during the treatment with this bispecific molecules, what did we see in this patient? Initially, he had only a grade 1 CRS, which was treated with steroids. He had no neurotoxicity. No infection developed, although in the trials where patients were treated without an IVIG, developed a significant percentage developed infections, mostly pneumonias, and then subsequently most patients got IVIG-aware infections were ameliorated. So in this patient, we gave him IVIG monthly. He had no infection. Now, after a few cycles of teclistamab, he started to have some neutropenia where he's getting GCSF weekly. This I conclude. Thank you.